Will that capture the speaker?
I haven't been able to test nobody's joined yet, but yeah, up to you if you want to.
There, it's not about us.
Okay.
That voice.
Sounds good.
For us short people.
We were just talking about that. I'm not even that tall.
I know, really.
You can't bring this down.
Oh.
On the one side. Yeah, unfortunately.
Let's see the camera that is filming us. Oh yeah. So if they come over here, which I think they're.
It's pretty wide. So you can like way over here.
Okay. Yeah, I read the one right? Yeah, no, and where they go down. But I'll face the camera and your height. Yeah, like I had to stand over here. Like that's hilarious. Yeah, right. That really blocks your face. Not for the camera, but so where are you comfortable? But even there. Or would you stand over here? I can stand wherever you want. Oh, wherever you're comfortable. We'll just adjust this depending on where you want to be.
This is how it looks. So they'll get you.
Slides go on blue screen, right? Yeah. So it's just kind of showing that you're here. Yeah.
How does that work for you?
Yeah, we use design.
Okay.
So
can you see me way in the back? What is it? Wherever you want to stand. I just want to. I should wear heels. I never wear heels.
No.
No. Is that okay? Quite tall. Yeah, and it like we tried it.
Yeah.
Oh wait.
Oh.
Oh.
Nice work.
Yeah.
Let's give her something. Look at this. Oh, that's way better. Is that better? Well,
it is.
For you, I'd be able to present it and you're not looking.
Yeah, you can sit at the shortest and then.
Okay. Okay, then we can do that. You do. Very small. I sure do. So I was like, well, that was a waste. Yeah, sure. Better put it that way than I want to get myself.
So what about the other two?
They are.
Just gotta click into the PowerPoint and then hit escape. Yeah.
They are right
all in there,
and they're all being shared. So as long as we see that, okay. We are golden for
but we need to make it. Okay.
So they're all shared. All the full PowerPoint.
Can we?
Well, once you view the presentation,
she won't present her view. So,
I don't know those things.
Here, let's just change.
Is the presenter view what to do account? A little bit of attention.
Yeah, it can be a bit strange with the way we've got it set up. So
I'm a bit, because I imagine that she wants to see her slides, but she doesn't want to.
Yeah. You can try first.
Trina, water up.
Have you got a laptop somewhere that we can see what it looks like for people online?
This is what it'll look like for people online.
Okay,
you're sharing just the screen.
Yeah, but we've got a wee bit of attention there because she wants to be able to see her speaking notes, I think. So we might have a wee bit of a. Okay, that's fine. Okay, we're fine.
Okay.
Okay, I think we're about to begin.
All right, sounds good.
And I'm online here.
Yep.
Right. Did we have do we have a sense of who, if there's anybody on?
Just hit escape there. I don't believe anyone else is on. Just us that are connected right now.
Yep.
Yeah.
Okay, we might get somebody, and we'll, it's quite good to be able to make them quiet if we need to.
Yeah, exactly.
How do we do that?
Just hit this little.
That's us muting, and then we press the down volume.
Yeah.
If we hear
if you want
anything.
to adjust the volume.
Okay. All right.
Sounds good.
Excellent. So welcome everybody. I'll get you to take your seats and settle in for this exciting, for the last Health Research Institute seminar series for 2018. We've obviously got a different audience for today, because sometimes in our Health Research seminar series we have groups from courses, but because we're in exam period, we've got a different crowd. So thanks for being here. We've got people from across campus, I can see, and also we're really delighted to have some folks from out of town, which is exciting, and we're really always pleased to welcome everybody here. For those of you that don't know me, my name is Margot Parks. I am hot off the boat from New Zealand, so my accent is a little bit stronger than usual. I've had to relearn to say my name is Margot Parks, not Margot Parks, which is what it is when I'm in New Zealand. And I'm really happy to have been on the Health Research Institute Leadership Council now for some years. And that's one of the impetuses for this seminar series, where we're bringing health researchers from across campus to be part of ongoing conversations. These are some of the groups that are involved in this series. And we also have from the Health Research Institute a range of those involved. Today's a special day because we're really delighted to have our colleagues from the Michael Smith Foundation for Health Research Council here who are having a series of conversations. They're already full of the brilliance of UNBC Health Research because they've been meeting people in half-hour blocks for the last while. So this will be very relaxing that you're getting to hear our seminar series profiling, but also very clearly for all of you that you're invited to be part of a further conversation with this group and I'd really encourage you to join in on that conversation. Somebody will need to tell me where it is. Next to this, okay, the Farmers Market room next to the Thursday Moot. Yeah, the Nusk space. And then we've also got, importantly, a really exciting holiday social with some of our trainees at various levels, coordinated by the two student reps on our Health Leadership Council. So kudos to both Damon and Shayna for organising that. So today we've been realising with some enthusiasm that not only do we have an array of faculty across UNBC to be profiling, and we haven't even begun to scratch the surface of the talent across our faculty in health research, even though we've been going for a couple of years now. We're also really excited to be profiling the work of PhD alumni. And today we're going to hear from both Trina Fyfe and Susan Burke. What I'll do is I'm going to introduce Trina first. We will have Trina's talk and a chance to ask a few questions. Then we'll move into a session with Susan and have a chance to ask questions. But we're really hoping that we'll finish up with a little bit of a bigger picture kind of discussion, because although, as you can see, these are very different topics, there are also points of resonance, and part of what we do at the Health Research Institute is we celebrate the fact that across the range of our research, there is often some really common themes and synergies that are worth speaking about, as well as the specifics. So a heads up for you that are not aware that we'll be carrying on next semester, and the first speaker on January 8th is Luke Harris, which we're really excited about, from the School of Health Sciences. For those who want to encourage those that couldn't be here to watch this session, they are available on the Health Research Institute website. They are videoed, and there is a lot of traffic over time, people coming and learning about it, and also our speakers will be able to direct people there. So it's really a great pleasure now to introduce our first speaker, Trina. I have really enjoyed working with Trina since I've been here in 2009, but Trina's been here before then, working with the Northern Medical Program as a health sciences librarian, but also developing her own research strengths and interests. Trina has a master's in information studies from the University of Toronto, and has developed through her PhD at UNBC within our school, within the Health Sciences PhD program. She's developed her research, which is focused on decision-making processes involved in dealing with low occurrences in clinical situations, and particularly understanding what this means for rural and remote populations. So Trina, really a big thanks for everything that you do for so many researchers, health researchers, but also for being able to do that and to pursue and share your work. So I'll just pull up your slides here. Here is Trina.
Perfect. Thank you. Awesome. Thanks. I'm just going to move this glass of water. And I'll try not to spill it. Okay. Thank you so much for inviting me to come and speak, and to come and speak with with Susan, we started out a PhD together back in 2012, which seems like ages ago. But as we were just talking and catching up, time goes by really fast. So here we are. So this is kind of cool for me to kind of bring it back together. So I'm going to talk a bit about the PhD work that I did, which I'll tell you a bit more about. And this slide is really for me. I have nothing to disclose, but I want this presentation to be really awesome. So I'm just going to tell you it's awesome, which will make me feel better. But I do have some acknowledgements. So I have my co-supervisors, which were Dr. Jose Lavoie, who's now at the University of Manitoba, and Dr. Jeff Payne, who, of course, you know here at UNBC. And my committee members included Russ Callahan and Suzanne Johnson and Davina Banner. It was also partially funded by the Don Walker Award, which really helped me kind of get this project off the ground. So this is where I'm going to go today. I'm going to talk a bit about, I'm going to contextualize it. And for some of you probably heard our story before, but I'm going to share that with you because it's really important in kind of laying the land of how I got into this, trying to develop my program of research, and the knowledge synthesis that came from that, and how that then led to developing the research question I then asked for my PhD project, and then sort of where I'm at right now. So this all began back in 2009 when our son Foster was born. And when he was born, we realized quickly that we had blood incompatibility, which meant that my body had developed the antibodies and literally was attacking his red blood cells. So, and I'm going to talk a bit more about the mechanisms behind that. But what happened was, so in order for him to thrive, let's say, within the first 4 hours of life, and then 4 days later, he needed immune globulin transfusions to help boost up his red blood cells. And luckily, because it was Conan time, he is this fine young man over on the side, who this morning winked at me and said, "Jimmy's back in town." And I was like, so he's quite fine. But you know, it could have went sideways, right? We had it was a very tumultuous time. It's not something that's supposed to happen. And so, you know, it was really important for me to I kept asking these questions. Why did this happen? So let's talk a bit about why this happens. It only happens in very specific circumstances. So you have to have kind of all these pieces put together for it to occur. So the mother has to be Rh negative. So and the fetus has to be Rh positive. And that's the only time when, say, a sensitizing event occurs, such as bleeding, pregnancy, trauma, an abortion, or a threatened miscarriage, or even a miscarriage, these, or even birth, actually. So at birth, this can be a sensitizing event. And what happens is that's an opportunity for the bloods to cross. And so if the blood crosses the placenta into the mother then develops antibodies, which then goes back into the fetus and tries to attack its red blood cells. And so this can have devastating effects. It can cause fetal, death of the fetus. It can cause all sorts of long-term complications. And in neonates, usually what happens is they have high, this is a word I'm terrible at saying, but hyperbilirubinemia, which means severe jaundice. So, and that's what happened to Foster. So his levels went quite high. And in order for them to come down, he needed to have the Billy lights, but he also needed to have the immune globulin transfusions, which is made direct from plasma. But like I said, and I have this word up here because I wanted to make sure, sometimes I don't say this very often, but it is 100% preventable. So there is a prophylaxis that is, if it's given at the right time, can prevent all of this from happening. Excuse me. So, and it's really fascinating because it's something that doesn't occur very often, right? Rh alloimmunization sometimes it's called Rh disease, sometimes it's called Rh isoimmunization, but I like to call it alloimmunization. It was discovered and significantly reduced within the same century. And so within the early 40s to 1960s, the mechanisms were identified and then the prophylaxis was developed, which is pretty fascinating. And then it's significantly reduced prior to by the end of the 21st century. So, and the gold standard of prophylaxis remains today, which is the RhIg or Rh immune globulin. And actually, it's 2018 is 50 years of having that prophylaxis in place, which is pretty fascinating. And of course, the guidelines, there's international guidelines, but there's Canadian guidelines that weren't put in place until 2003. And then recently updated, of course, just as I was finishing my dissertation, which always gives people panic, right? Were recently updated in 2018 through the Society of Obstetricians and Gynecologists. But it kept coming back to, again, so why did this happen? And so I started my PhD in 2012, and Dr. Shannon Wagner at the time had kind of encouraged me. I had written a piece for our seminar class, and she had sort of suggested, this would make a really great scoping review. And I thought, well, I didn't really think about that. So I then kind of approached Northern Health, who had already been familiar with our story because I had talked to them about this as a way of educating and generating some awareness. And so we put together a team of practitioners and decision makers, and we asked the question whether or not women were receiving the prophylaxis at the right time in pregnancy. And what we found was that Rh negative women are still at risk. So they're at risk in emergency rooms, they're at risk in primary care offices, and they're generally at risk because they'll enter the system and then they're often not, their Rh status or their blood type is not identified, and so they leave before that happens. Or there isn't any follow-up to identify, to see if they were Rh negative and if they needed any follow-up. So there was lots of reasons in place, but what was missing was why? Why is that happening? There's still current research, not a lot of research, but there's still current research happening. The Canadian Pediatric Society I'm showing the results here, the 2016 results, but they're doing a prospective study right now to identify how often, the incidence rates of this occurring. And in the UK, they also are doing prospective studies which they should be, I think, wrapping up now. Same as the Canadian Pediatric Society. So I'm kind of really kind of waiting for these results. But what the early results have shown that this is still a problem. Women are still becoming sensitized, and in their first pregnancies even, and even after. If we kind of back up a bit though, we have to really think about this in the larger picture, right? And, you know, because it's preventable, it essentially is a patient safety incident, which is the terminology used by the Canadian Patient Safety Institute, which I just got an email the other day and they're thinking about calling it something different. So right now we're calling it patient safety incident. And, you know, I still get a little alarmed when I see things like 5.6 of hospitalized patients experience harm. That's 1 in 18 patients that are hospitalized. But we know that, you know, individuals making decisions within large, complex health systems, you know, can be slightly problematic and can lead to some of this harm. And also that when the harm happens, that patients really, they want information about it. And, you know, if they don't have that, that's often what leads to litigation and malpractice suits. The other piece we have to think about is the decision making, and you know, a lot of my work has kind of been involved in, as a librarian, has been in evidence-based medicine, right? And you know, making sure we have the best available evidence. But not always is the best available evidence actually helpful in making those decisions when you need it, due to lack of evidence or low levels of evidence, and in particular in rural areas where the context is different. And the other thing you have to think about is cognitive biases. So heuristics that are made by, you know, we keep doing the same thing over and over and over again because it works, but essentially there's something still happening within that can lead to patient harm. And then the shared decision making, which is sort of our ideal, right? That having the patient sort of involved in making the care. But if you have health literacy concerns or lack of health literacy, and also there's some information behavior going on where patients want information or they don't, that kind of conflicts with that shared decision-making process. But what's missing from that larger literature, I don't know how I get that away, is, you know, what's the impact of decision-making processes in the management of low occurrences? And what I'm going to focus on is specifically the prevention of Rh alloimmunization as a low occurrence. Because only 15% of the population is Rh negative, and so if you start, you know, kind of whittling that down in pregnancy, it's even lower. We don't actually know how patient safety incidents in rural areas are managed or dealt with. We don't know that. And we also don't have a lot on how guidelines are adapted within rural areas. And all of this sort of leads to my research questions with a specific focus on Rh alloimmunization. So the purpose of my PhD work was around, you know, why are women still at risk? And we know they're still at risk from the literature, from a lot of those retrospective studies that we found in the scoping review, but we didn't know why. And so we wanted to look at that within the context of northern BC. And so we thought, well, let's ask women about their experiences. And let's ask providers about the experiences of delivering the care to these women. So we did that through a few ways. I used an interpretive description, which was created by Sally Thorne. Have some of you heard of it? Mm-hmm. Okay. So it is an applied research approach. In that, the idea is that the findings are applicable to practice, right? And it's what was really important for me, why it was important for me to use that was because I really wanted to ensure that what I found was actually going to be applicable to practice. We'd be able to take those findings and turn it into something that could potentially help generate awareness or change in Northern health. Now, I did use a constructivist ideology or ontology. However, and I always struggle with this because interpretive description kind of pushes that boundary on constructivists. So with constructivists, right, the idea is that when you look at the data, patients have shared experiences, or your participants will have shared experiences, right? But interpretive descriptions allows you to say, well, actually, there are some that will have their own individual, and those count, and we need to incorporate those within the findings. And that's particularly important for me as the researcher, but also the person who experienced the phenomena, right? And that's where a lot of reflexivity came into my work. And I have put a picture up here of me on top of the Eiffel Tower this summer, looking down kind of on everything, trying to figure out all the nuances. And I thought that was kind of like me doing my research, where I'm looking down and I'm trying to figure out what all of these experiences are, what the nuances are within there, and what the patterns are, but also I'm fitting myself within that. And I have to, right? Interpretive description, it doesn't want you to bracket yourself, if you heard that term, some of you. Yeah, right? It's where I have to be part of this research because I have experienced it. And there are ways in which I made sure that I didn't bias my process, in that I did reflective journaling, but I also included a stakeholder committee, which I'm going to talk a bit more about. So I interviewed Rh-negative women who had been pregnant since 2004, because that's when 2003 was when the guidelines were developed. So I wanted to see what had happened after that. And I also interviewed healthcare providers, and that was anyone who did prenatal care. So midwives, nurse practitioners, family physicians, emergency physicians. And then I brought the findings, the early findings, always back to the stakeholder committee, which was made up of, similar to the scoping review, made up of decision makers and healthcare providers at Northern Health, who could not only provide me with some of the clinical guidance that I don't have, but also could tell me whether or not what I was bringing back was relevant. And also they could ask more questions. So then I could go back to the data and take a look and do a bit more digging, or I could do some more interviews and ask them different questions. And so the analysis was kind of always going throughout across this process. I interviewed 16 Rh-negative women across the north, 13 healthcare providers, and again, they were anyone that had that offered perinatal care in some aspect, and then there were 8 stakeholder committee members. Okay. So, what did I find? I found that Rh-negative women are uninformed. They don't fully understand what it means to have an RhD status, negative status, and actually what that means for pregnancy. They realize there's a risk, but not necessarily what the risk is, or the magnitude of the risk, let's say. And they really didn't understand what Rh immune globulin is. Few of them didn't realize it was a blood product, which it is, and you have to have sign informed consent, or how it works to actually, prevent the D antibodies from happening. And I heard a lot of women, they were really uninformed, and they really talked a lot about communication. So they didn't feel there was a lot of communication between their healthcare providers, between the healthcare system, in regards to this, in regards to their pregnancy as an Rh-negative woman. And that was across the board. Healthcare providers told me a bit of a different story. They said, and I don't put this quote here to be, I don't think the provider was being flippant, but I think they were expressing how a well-oiled machine, right? An Rh-negative woman, we find out her blood type. At 28 weeks, she gets a form, she goes to the lab, she gets her blood tested, she gets the immune globulin, she comes back to the office, and even as I'm describing it, I'm like, that's kind of a lot of steps to go through to get a shot, right? So there's a lot of barriers, but they felt that it was working really well. However, they still needed some support. They too didn't realize what it was, how it worked, or how to explain it to patients very well. They struggled with that. They also told me that women aren't asking for it, so they don't advocate for it. They're more likely to go into the emergency room when they're in the emergency room and ask for something like vitamin K, and nothing about their RH status. They all talked about shared decision making, how they really wanted to work with patients, and sometimes, noted that that didn't always work out well. And this is my shared decision-making slide. When they realized, all of them talked about, wanting to have information. So the patients talked about wanting to have information, wanting to be part of the decision-making process, and the healthcare providers wanted that too. So I kind of use a yin-yang symbol to show that sort of balance of power, where the balance is, evenly throughout. And I'm going to kind of keep coming back to this symbol. In resource-limited areas, so in your rural and even remote areas, what we found was that the immune globulin was not actually readily available. Because it's blood product, it has a shelf life. So you can't keep it on the shelf for very long. That would be very expensive if it's not used, right? But when someone has a sensitizing event, they had to then find a way to circumvent the system, send the patient to another center in order to get it in time, which was problematic. Like, it led to a lot of opportunities for the patient not to receive the prophylaxis, and then of course it runs the risk of developing D antibodies. So the processes were not always in place to do this. So I'm going to come back to this in the discussion around the shared decision-making model, the ideal shared decision-making model, and how what I found in talking about a low occurrence event like RH alloimmunization can kind of can mess that up. So the one where the little point is kind of up now with the healthcare providers is really what the women told me. They told me that when they felt uninformed, right, the balance of power shifted, and it shifted up towards the provider. Now, some women, are comfortable with that, but most of them were not comfortable, and they felt that there was an imbalance of power. The other one, where we have the hash marks throughout, is where the providers are, they're struggling with the information, how to deliver the information, how to get their patients the care that they need. And in both of those situations, now you have an opportunity for the development of D antibodies. And then when you put that decision-making within the full complex health system, and you add rural on top of that, you have so many opportunities for the gears to break, right? And this is what we found. We really didn't know what all those nuances were that can kind of end up sort of breaking the process. So the recommendations, based on the recommendations from the stakeholder committee, we were developing a patient education tool because it was felt that was missing from Northern Health complement of information. The development of, say, like a flowchart tool for healthcare providers to use and adapt rurally so that they can identify the process ahead of time, who they need to call in the other city or the other town, and who would give the shot, all that kind of stuff. And then also the development of D antibodies is never investigated. So even though we know this is preventable, women who develop D antibodies it's kind of being left alone. So there's no identification that it's a problem, and no one's looking into why it occurs. So where am I now? So based on that, right now, I've, with a team of people, and over on I always get the left and the right, and Keelan's gonna laugh at me because we talked about this earlier, but over to our health literacy and perceptions of risk. So I was fortunate enough with a team of people with a really great patient representative. We have a a grant to look at the health literacy in low recurrence populations, such as Rh negative pregnant women, and their perceptions of risk. And so we're still we just got the grant, and we're still sort of figuring out how we're going to approach this. But we think it's something that really needs to be teased out a little bit further. And then what I didn't talk about, because it only came up a little bit in my research, but abortions are a sensitizing event for an Rh negative woman. And what I heard from some providers in rural areas was that it was problematic for women, not only to get those services, but also then to receive the RHIG in those instances. And so they faced a lot of barriers in that process in delivering those services. So we have a small collaborating grant with Shona Mitchell Foster to actually look at accessing family planning resources and services in northern BC. And we're working with Carriers County Family Services on that too. And then the one on the dotted line is I'm just starting. I just found those people that are doing the prospective studies in Toronto, and I saw another blurb about Dr. Jillian Baker at St. Mike's who has kind of said something about patient experiences with Rh-Alley immunization, and I was like, oh. So I have a tentative. This is where I would like to go as well, and actually talk to women who have experienced Rh-Alley immunization, and go from there. That's it. Thank you.
Thank you very much, Trina. I'm sure you could facilitate discussions and questions yourself, but we have got a time now to open up for questions. We will have Susan to follow, but some crossover at the end. But some questions I've got lots, but some other questions for Trina? I'll start things off, Trina. I'm just really curious about, at the broadest brush, whether when you were really digging into this particular story and thinking about rural and remote northern BC and the particular ways this rolls out, was there other kinds of low occurrence illnesses that you were sort of comparing to? Were you finding was there any help from how other if there's other illnesses that sort of are comparable, that had some of the same characteristics?
I didn't intentionally do that. I'm trying to think if I heard anything. I think we kept it super specific in that, in order, again, to sort of make the findings applicable to practice, right? So it was kind of sometimes hard, and that was a bit tricky, I think, throughout the process with the stakeholder committee, because sometimes you have those bigger conversations and they wanted to bring it back to something that was more specific.
And I'm not surprised, because what my second question was about the way in which, because this is all caught up in the whole perinatal story of northern rural remote sort of services, I also wondered, given this is a really specific story that warrants attention itself, did it get confused by other anxieties around that the perinatal experience? Well? How did that play in?
Yeah, and that I'm sure if I went back into my data, I could kind of tease some of that out. And it was really around travel and lack of sometimes provider-patient relationships. So some really felt when they had to travel to Prince George or elsewhere for their care, then they lost that relationship. And so I heard a lot of that.
Yes, there's a question up the back.
Thanks for the presentation. I have a question, and maybe it's because maybe your story is a little bit unique, I'm not sure, but from my understanding, typically we use program in the prevention of health consequences like hemolytic anemia of the next infant. So I was wondering, in your research, that you found in the scope review that women are still at risk, and typically women are tested for the antibody in pregnancy, and then if they're antibody positive, they receive program at 28 weeks, and then if they deliver a B positive baby, then they'll receive it like program again. So are women are you finding, and I don't know if you have you can check, but are women most at risk during pregnancy, one, after pregnancy, or during those events where there may be like spot contamination, like you discussed, like early bleeding, convulsion, that kind of stuff. Did you happen to see like where we're actually missing women?
So we're missing women in those sensitizing events, right? Oftentimes, a lot of the studies were done in emergency rooms. So, where a woman would go in because of a bleed, and then kind of things would fall apart after that. And I heard from emergency room physicians that that's not at the forefront of their mind, right? So they're taking care of say the threatened miscarriage, right? But not always the RH status, and actually the amount of Rogan that's supposed to be, or Winrow is supposed to be given, is contentious and all that kind of stuff. The other part of your question, though, there's not a lot of research on, like, it's lacking in around what constitutes enough bleeding to cause a sensitizing event, right? And everyone has always said, the research says, well, it's not a problem until the second pregnancy. And I put up a slide at the beginning, or close to the beginning. There's the serious hazard, and I always forget the something transfusion in the UK, and they're doing a prospective study on first trimester sensitization. And so, because we don't have any information on that, so I'm really looking forward to seeing what comes out of that study. But I think they're still it's winding down.
Another question.
So, as a non-scientist, can you help me understand how those 3 or 4 different things are sensitizing events?
Yeah.
I don't understand
No.
the term sensitizing event.
Yeah, no, and that's, so what happens? Yeah, sorry. Well, it's just because I can't explain it without a slide, right? And so and I don't fully understand this part either, full disclosure, in that, yeah. And I think that's what I heard from providers too, is that they're like, I don't know, it just happens, right? But what happens essentially is when a sensitizing event occurs, for some reason, the blood crosses the placenta from the fetus into the mother. And maybe, is that right, Christine?
Yeah.
Yeah. And so then that's the opportunity where the mother her red blood cells identify it kind of as a, like, Pac-Man kind of as a foreign body, and then, tries to develop the antibodies, which then goes back in. And
in the case where a woman is having a therapeutic abortion, then the risk is for the next time
yes,
because that has occurred.
yes, exactly, yeah. And so they would give the RHIG prior to doing the abortion in order for it to ensure that. Yeah.
Thank you.
Yeah, no, thanks. Good question.
Here's another question.
Yeah.
Thank you so much for your presentation. And one thing I really did was how creative you and I was really clear on how that experience, maybe having a foot in the world of researchers, but also a foot in the world of the experiences you were studying. How did that shape your experience doing research?
So it shaped personally. I have to talk about because personally it totally changed my viewpoint, right? So I kind of was very angry starting, and was very like, okay, I had my biases of what I was going to find, and I made sure I kind of wrote all those down, reflected on that a lot. Poor Jeff and Jose. And then, but over the course, right, my perspective changed, and I don't think. So my understanding too of the healthcare system changed, which then I think as a researcher, I can't still even begin to fully understand the complexity of it all.
Mm-hmm.
And so, you know, and I'm kind of struggling a little bit with current projects on how I'm going to address that. And I really am. Mm-hmm. I don't know if that answers your question, but that's kind of where my...
I think it's a really nice place to wind us up, and we may be able to pick up on with after Susan's talk, because that recognition that you've done some really important work here to help understand a really complex situation, but you've only scratched the surface, and that you've got, and that's one of the challenges when we're really trying to understand things in situ. So I really enjoyed being able to finally hear about your research. Thanks, Trina. It's been really neat to hear from you.
Thanks.
I'll do this.
Yep.
So I think it's worth mentioning that when I introduced myself earlier, that I mentioned that I was just back from New Zealand, which was partly it was actually intended to mention how glad I am to be back in Northern BC, and how glad I am to be back on Lheidli territory. But also back I've just been in New Zealand and talking a lot about what I value a lot about being at UNBC, and these kinds of scopes of health research all in one university, but also a health research institute that brings them together really makes a difference for wanting to be here. But so too is the fact that we are slowly, not fast enough, but slowly as a university, seeing the next wave of scholars that are going to be the kind of champions that we want. And I think we've already had one example of that. But Susan is a much appreciated, relatively new assistant professor here at the UNBC School of Social Work, as well as her BA in Geography and her Masters in Social Work. We're really delighted that Susan chose to do her PhD here with one of our first graduates in the School of Health Sciences PhD program, and is bringing lenses to our perspectives both through her past work and some of this emerging work that we're really excited about. So thank you for sharing it with us.
Everyone's going to be able to see that if I stand here. Thank you so much, Margot, for the introduction, and thank you everyone for coming out today. I am not going to be talking about my dissertation research today. That topic was cognitive dissonance in social work. It's in the library if you're super interested. Today I'm going to be sharing, I guess, some ideas with you around my thoughts around how we can do a better job of teaching about colonization in the post-secondary classroom. So I'm going to be talking about my research in the context of social work practice, but I really invite you, if you're a faculty member from another program, I really invite you to think about and reflect upon the findings and the recommendations in the context of your program. I'm going to be talking specifically about the needs of Indigenous students. I personally feel that when we create safer classrooms for Indigenous students, we create safer classrooms for all of our students. So I invite you to think about the recommendations around the needs of all of our students. And then I also, if you're here and you're not ever going to be teaching or don't ever plan on teaching, I still really invite you to think about how you can be an ally in this really, really important work that is unfolding. All right, so this is the basic format I'm going to follow today. I'm going to go through the first 4 sections fairly quickly, tell you a little bit about who I am, discuss my literature review, my research questions, how I went about doing the research, and then I'm going to try to spend the majority of my allotted time talking about my findings and my recommendations. So a little bit about me. I think it's important that we always have a little bit of an idea of the lens that a researcher brings to their work, right? So that's a picture of me and my 3 children. They'd kill me if they knew I was showing it right now, but I don't care. My prerogative. So I'm a mom. I'm Métis. I'm a Métis woman. I was born and raised just south of Prince George in a rural community where I still live. I'm the mother to 3 young adults, 17, 20, and 22. 2 of them are going here. One's applying for next September. Thank you, UNBC. And I was a frontline social worker for about 20 years before I started teaching here full-time around 4 years ago. So those are kind of the, I guess, the positions in my life that I brought to wanting to explore this idea a little bit further, right? My role as an Indigenous woman in this community, a mother raising young Métis, Gitxsan, young adults and helping them navigate this world. My previous experience as a frontline social worker, as a child welfare social worker, and then now this huge honor I have to be an instructor of social work students and help prepare them for practice. I started here in 2009 as a professional, and I teach mostly Indigenous content courses, and I really approached the classroom thinking I got two groups in this room, right? I have the Indigenous or the non-Indigenous students, and I need to teach them about the 60s group and residential schools and help them understand all of that. And then I have the Indigenous students, and they already have that hard-earned knowledge, right? And what happened, quite honestly, it took me a few years to clue into this, but at the end of the semester, I would read students' journals, and I realized over and over again that the Indigenous students, the First Nations and Métis students were saying, I went home from your class today and wept, right? I went home from your class today and I finally understood why my grandpa was always so quiet, right? Or the other one I heard, Susan, I tried to make it through the 3 journal articles that you assigned for this week. I could only read them 2 or 3 pages at a time. It felt like the author was writing about me and my family and my community, and it's just super hard, right? So just this growing awareness in my own mind that maybe I needed to be a little bit more mindful about how I was approaching the classroom. Most of you will have heard, or many of you will have heard in 2015, the Truth and Reconciliation Commission of Canada published some calls to action. Essentially, I think those calls to action led to a lot of post-secondary institutions across the nation starting to think about how we implement Indigenous content, not only in more obvious programs like social work, but really in all of our programs, in all of our classrooms, right? And then, the literature shows some things very clearly, right? The Western education of Indigenous peoples has hugely colonial roots. We have small but growing numbers of Indigenous post-secondary graduates, and I can see that in these hallways and in my classrooms, right? That the numbers are going up. The literature talks about the lack of fit for Indigenous students and around sort of having to be in institutions that operate from a Western perspective and how that impacts recruitment and retention. The literature talks about how learning about residential schools and 60s scoop can traumatize students. It also talks about how, this whole move to make Indigenous content mandatory can have a little bit of a backlash because sometimes you end up having students in the classroom who really don't want to be in the classroom and aren't interested in learning about that, right? They're there to learn about physics or whatever. And that can lead to racism and stereotypes and just a general lack of understanding of privilege, right, of white privilege and how that impacts the way you move through the world. And then finally, the literature talks a bit about how, when we only talk about the stats, and we really tend to do that, I think, in academia, where we'll talk about, the overrepresentation of Indigenous people in the child welfare system or in the justice system, and we talk about sort of what we can do about it, but we don't kind of spend time sitting in that uncomfortable middle spot where we explore why are those numbers the way that they are, right? Why are there more Indigenous people? Why are they disproportionately represented in these institutions? And that can lead, I think, it can both perpetuate racism and stereotypes in our post-secondary classrooms. And it can also impact Indigenous students in feeling like they're being pathologized, right? Like they're broken and their communities and families are broken. So the questions that I wanted to ask, again, this was secondary research from my dissertation data. I wanted to look at what are the experiences of Indigenous social workers in learning about colonization sort of over the lifespan, and then how can we use that information to help inform how we're doing this important work. For this research, I looked at the 9 First Nations and Métis social workers that I had interviewed. They were from 5 different communities across BC. They were all very highly educated and very experienced in their social work practice. I'm not going to talk about this a lot. I use the Métissage framework. That's another presentation, and if you're interested, I will gladly tell you all about it. I conducted semi-structured interviews and used basically a thematic analysis for my data analysis. So I very, very clearly had three themes that came up, and the social workers that I spoke to, they talked to me about how prior to going to post-secondary school, the impacts of colonization were very much felt in their everyday lives, but it was an unnamed lived experience, right? They didn't know why they were experiencing what they were experiencing necessarily. It's not something that you talked about, over at the dinner table or whatever. And they talked about how once they got to post-secondary school, that they gained sort of that academic cognitive knowledge, right? Suddenly they came here and they went, oh, like I said, now I understand why Grandpa doesn't want to talk about when he was little, right? Now I understand where the drinking comes from, right? It's all starting to make sense. And then finally, the social workers talked to me about how it really, really hit home to them in a different way once they entered professional practice, right? Once they got out of school. So I have some quotes to show you, or to demonstrate. So this is from one of the social workers I interviewed that talked about how she grew up with these experiences. We experienced it firsthand. We got acted on. It was happening to us, but I didn't understand it. And nobody ever explained to me as a child growing up, when you see your friends dying and you hear adults say rheumatic fever, drowned, died in a fire, died in a car accident, nobody is saying they were drinking. No one was saying the parents weren't there. And no one was saying, why weren't the parents there? Oh, they were drinking. Oh, why are they drinking all the time? Is there any underlying cause for changing the way you feel? Using alcohol or drugs or pills to change the way you feel? The pain and the hurt, the memories, the childhood. Nobody explains all of that to you, and you're growing up and you hear your friends committed suicide. They were found hanging in the trees. So my experience of colonization, you just experienced it without anybody explaining it to you, but you sure don't forget it. And as you grow into your adult years, you try to make sense of it. This is a quote to demonstrate that the second theme that came up, which is around how it became sort of that academic cognitive knowledge in school. It was quite an eye-opener for me. So all these puzzle pieces are coming together. That's when I started understanding the history of my family, my nation, community, stuff like that. And why all this stuff was, where it currently is still today for the most part. I had to take a First Nations-based course there as well. So that's where I learned the majority of it. I was like, holy crap, just, realizing there's a huge, legacy, I guess, of mistreatment of Indigenous people, which continues to this day. So in terms of violence and substance use and all sorts of stuff, and just knowing, my mom always told me that she went to a residential school, and my grandmother actually went to a day school and then a residential school. And my mom had mentioned off and on her experiences in some of it, and had also alluded to some of my grandma's experiences. And I'm like, maybe it was, they just went to school. That's what I thought until, okay, it wasn't just a school they went to, right? Okay. This social worker, I'm just going to read part of this, but this social worker, this is an interesting theme, or I guess kind of sub-theme that came up, where she was talking about the pathologizing that she heard in the classroom wasn't consistent with her lived experience as a First Nations woman. And she says, all I knew was my family was my security. Even though they weren't perfect, we went through everything together. If I didn't have my family, I don't know where I would be. It was a rough upbringing, but I couldn't have gone through everything without them. So I find it hard to believe that everybody in a family is unhealthy because I know they're there. So she basically is just saying what I learned didn't jive with me. Okay, and then I have a couple of quotes to demonstrate the last theme which came up, which is, I think, it really hitting home for people once they entered practice. So this is a social worker who ended up working in child welfare. And she says, I was asked by my team leader to go out to one of the rural communities up north, and basically was told that there were no First Nations children on that reserve. They had all been taken away. And I was really taken aback because, hearing that in your studies and theories through books and then actually seeing it in that day and age and knowing that there are no children left in that community, it's really heart-wrenching. And it really hits home when you actually see that occurring. You kind of think, oh, this happened a long time ago, 60 scoop and all this stuff that we learned through our degree. But to actually see something like that takes you back, and it really makes you think about where kids are being placed. How well are we doing our work? Are we really taking that time to explore family options? All of these things are so important. And then this is, I think, my final quote, and this social worker talked about seeing sort of the stats firsthand. If 80% of Indigenous children are in care, how can it be working? And when I first heard that foster homes were the new wave of residential schools, I was going, residential schools are pretty bad. And then you hear about the kids dying, you see the numbers, and it created in me a sense of being disloyal to my own people. So pretty serious repercussions. So I have some recommendations, and I want to focus on those. And these, again, are just based on what my participants shared with me, and I guess somewhat too on what I saw in the literature. I do think it's really important for us. I think there's a tendency now, and I hear this sometimes, where people are saying, well, now the elementary and the high schools have mandatory education on these issues, so now it's covered off, right? And I think we have to really, really be careful to remember that that isn't always the case, right? For a few reasons, right? I think our students come to us in a variety of forms, having a variety of different types of education. I think we can't assume that they've been taught some of the really important information around colonization in Canada. We can't assume that it's been taught well. My own children have told me horror stories about some of the curriculum that has been taught to them in our high schools here in Prince George, right? Teachers telling them there's no longer racism in Canada. It's really, really horrible, right? Nothing like hearing a bunch of football jocks talk about that around the kitchen table, let me tell you. But we can't assume it's been taught well. And we also, I think, have to remember that we're usually the last level of learning for people, right? We're able to, I think, invite these discussions when people are in a different developmental stage as adults than they've been previously, right? So it's always, I think, going to be an important time. I think if we're going to be teaching these topics, I think one of the most important things is that we need to remember that colonization is not a historical event of the past, right? We're not teaching history, we're teaching something that is ongoing and that continues to impact people's lives in very, very real ways. I think that we have to remember that a lot of our students will still be learning this material for the first time. And I think for me, just something as simple as normalizing that, right? Saying before you're going to be having these conversations, giving students a heads up that, hey, this might be hard for you, right? I often will have staff they're so awesome, staff from the First Nations Center and the Wellness Center coming to my courses on the first day of class and just be like a friendly face to the name and just to say to students, listen, if things get hard this semester, like here's someone you can turn to for support, right? So just really normalizing the fact that it might be difficult. I think it's really important to create a safe place for students by building relationships. I think if you're going to be teaching this, you need to be taking the time to know your students' names, know who they are. I get all my students to fill out a little bio on the first day of class. So at the very least, I know who you are, I know where you're from, I know a little bit about your life. I would say, tell me if there's anything you think I should know about you, tell me, right? So create that relationship so that if it does get hard, that they can at least come to you. And then having support staff available, knowing where there are support staff available, right? If your university has a First Nations Center, if there are elders and residents that you can turn to for support. I belong to a mentoring group, like a national mentoring group, as an Indigenous faculty member where I mentor social work students from across the nation. So knowing that there are organizations like that if you have a student that's struggling, some random faculty member in northern British Columbia will support them through it as best as possible. So knowing where those things are, right? I think you need to be prepared to address the reluctance, hostility, and racism that turns up in the classroom, right? So for me, that means that I have to have a skill set around what I'm going to do when that happens, right? I'm a teacher, so how am I going to use that as a teachable moment? How am I going to set a boundary? That means that I have to come to class feeling grounded and try not to have my mind on 57 different things, so that when that happens, I see that it's happening, right? That I'm aware that I can do something about it and not leave people feeling vulnerable. It's important to create time and space to explore your own biases, stereotypes, and cultural indifference. I believe if you take this really important work on, you have to invest that time, right? We all have biases. That's something we talk about in social work. We all have biases. We all feed into what the media has taught us, right? And so we need to take the time to, I think, be involved in a continual lifelong process of unpacking some of that. Avoiding pathologizing Indigenous peoples by just quoting statistics, particularly one of my pet peeves. Some of the ways that you can do that, you can incorporate projects that explore Indigenous figures in your community or really in the nation or across the world. I often will invite Indigenous, First Nations, and Métis social workers and scholars to come into the classroom and share some of their experiences. If you do that, you have to do it carefully. So I'll just say that's done based on you having a relationship with people, right? I'm lucky that I have lots of really good relationships with Indigenous social workers and scholars. I think having Indigenous people come into the classroom to share, it has two benefits in the classroom. One, it gives the non-Indigenous students sort of a professional from usually that's honestly a different color than them, right, who can come in and who can talk to them about some of these things and show them something different from some of the stereotypes that they've perhaps bought into. And it also, I think, shows the Indigenous students in the classroom that there are people like them who have been successful, right? And as a side benefit, I've noticed sometimes they make really good connections after class and then keep staying connected after, which is awesome. Getting students into the community, I think we need to do less sort of classroom-based learning and more experiential learning. So whatever that means, right, getting people out to attend community events and get to know people and get away from just that sort of cognitive theoretical learning. And then exploring beauty, art, resourcefulness, and resiliency. So what's working? Where is their beauty? Where's their art? Where's their success, right? Less focus on what's not working and more focus on what is working. And then finally, sort of around that third theme that came up, I think we need to keep in mind that all of our students are going to experience or may likely experience a different layer of learning or different level of learning once they leave us and go out into the professional world, right? And so I feel like the onus is on us to prepare them for that as best we can. Some of the things I think we can do is just avoid oversimplifying the real world, right? And I think we can do that in our classrooms by keeping ourselves fresh, right? Keeping ourselves knowledgeable about what's going on, taking opportunities to engage in research, getting out into community, volunteering at events, you know, making sure that your information and your knowledge is new as well, and not just textbook learning, I guess is partly what I'm saying. Help students move past the theoretical understanding. So there's something called First Nations social work practice, right? It's a theoretical orientation for practice, and I think theories are helpful, but helping students move past sort of theories into the reality of work. So creating assignments that are both knowledge-based and application-based. So you might have a lit review, but then also having a case study, right? Or saying to students, I always ask students, how does this apply to your practicum placement, right? Like, it's one thing to talk about being a culturally competent human being. What does it mean to be a culturally competent human being when you're in a child welfare office, right? Like, how does that play out in the real world? Describe that to me. Meaningfully support all of our students, I think, in practicum placements, right? So again, I think providing an Indigenous mentor, I think, can be really important if that's what your student, if your student feels that would be helpful. And then I think taking time to sort of critically discuss that intersection between how we think theoretically that this work should look and how it ends up actually working in practice. I just have a couple more slides. I think this is my last one. And then teaching and modeling meaningful self-care. We're not very good at that as faculty. We kind of sit up in our offices with our doors closed and don't talk to people for days on end. I believe that's what I do. No, that's not meaningful self-care, right? So one of my I guess a big concern I have is often students will come to us and when we talk about self-care, they always say, well, I'll take a bubble bath, right? I'll take a bubble bath. And it always makes me a little bit sad, quite honestly, because I think if you're that social worker and you went out to community today and you saw there are no children left in that community, like a bubble bath is not going to cut it, right? So we need to be having some real chops around how we're taking care of ourselves. And I think we need to be modeling that as faculty as well. So being able to turn to an elder for support, right, and advice, especially if you're away from community and away from, sort of that being maybe more easily accessed. Going to see a therapist, right? There's no shame in that, and recognizing that that might be something that you need to revisit through the course of your practice. And then also being able to participate in traditional wellness practices like smudges and sweats. And I know lots of social workers who use drumming and circles and that sort of thing, right? So making sure that you're incorporating those discussions in the classroom. So that's my presentation. Thank you so much, everyone, for listening. And
Thank you. Well, so much in there to explore and dig deeper, Susan. I'm sure there's some questions from the floor. Anybody want to start? Trina's going to start.
Thank you so much and for the work. You were giving your presentation and sharing your recommendation. One of the things I was about is I'd love to hear your perspective on where you see opportunities for universities, whether as a whole, like maybe at the level of faculty department, to do better at equipping their faculty, whether it's non-Indigenous faculty who need to confront their own complicity in the violence of colonization and ways we want to relate to them, and also how to better support Indigenous faculty to be able to engage in the classroom and do this kind of colonization work.
Yeah, I think it's a really good question. I'm just going to speak frankly. No one's going to out me outside of this room, right? I think that there's lots of space for Indigenous faculty and for sort of the larger community to be supported in this work. And I do think that it's happening. I hear from, when I have students come from other universities over and over and over again, I hear them say that we are leading the way in this work, or at least that's their perception, right? So that really means a lot to me. So much more needs to be done. And I think what I would personally like to see, I don't know if anyone here saw Dustin Louis' presentation last year. Dustin Louis came here and he gave a presentation on decolonization in post-secondary education. And it was a really, really beautiful presentation. It's available on YouTube if you want to see it. But really, there was only a handful of faculty in that room, right? And mostly it was students, and most of us that were there were kind of already converted, quite honestly, right? So I think there is that, personally, and this is in my humble opinion, right, that I think there is that, there's a little bit of a tipping point, right, where you don't want it to make it mandatory for people, because then sometimes there's a backlash where people are angry that they're being forced to do stuff that they don't want to do. At the same time, I think that we could incorporate it. I think we could do a better job of making it more accessible, right? So I think sometimes we do get emails from faculty saying there's a town hall meeting. This is really important. We all need to be there. And lots of us come, right? So in my mind, why aren't these conversations at town hall meetings as opposed to if you want to come for a presentation on Friday at 4:35, we can all have a conversation about this. You know what I mean? So at a higher level, people saying, listen, these are hard conversations. They really are. But we're going to start the conversation and start talking about what needs to happen as a community. Does that kind of answer your question? Yeah.
Other queries? No, sir.
Your comment about the backlash really struck home.
Yeah.
I'm nursing.
Yeah.
And we have required courses in the first 2 years. And required experiential electives, with the idea that experiential electives will allow people to experience and not get that background. But what we've been finding over the years is that the way in which the courses that students have been taking, or I'm not sure if it's the staff, but there is backlash. So when they get to this 3 or 4, they say, not again. I don't need to learn. Are there some suggestions that you might have for addressing that backlash? Within for us in person, within the upper division, and it spills over. You can see it spilling over into the work environment, and what they pick up in the work environment, and I'm sure that's the same in social work. Do you have any suggestions on how practically you've experienced success?
Yeah, I think it's a really good question. And I think the other piece that's interesting is there also ends up being a backlash, as I'm sure you know, against the profs who end up teaching those courses, right? A lot of times Indigenous faculty are asked to teach them. Most of us are still pretty new in our process and don't have tenure, so those low course evaluations don't do us any good, right? So there's that piece as well, right, where it just perpetuates, I think, a larger issue. I don't know, there's probably people in this room, honestly, who could answer the question better than me. Again, in my opinion, I think change has to take place on a lot of different levels. And I think it's going to take a lot of time before we see significant change in all of our programs, right? I guess I'm saying that because I think if as a larger institution, our university embrace these things, if all of our programs embrace these things, if in our off studying time we embrace these things, I think that it would trickle down into some of those places. With that being said, like I teach the mandatory 3rd year Indigenous Content Social Work course, and I've taught it since 2009. And the truth is students do come somewhat reluctantly even to that course and say, I've done this all before. I think for me, first of all, I just tell them you need to come with an open mind, and it's like brushing your teeth. You do it more than once, right? You have to keep coming back. But the flip side of that, quite honestly, is I also feel like I need to pick up my game a little bit as a prof, right? Where I think if I'm teaching you stuff, if I'm teaching you social work practice with Indigenous peoples 101, and if that's what you're learning over and over and over again, then maybe I need to pick up my game too, right? Maybe I need to be breathing a little bit of life into the learning, right? So I think it's a two-pronged thing. I don't know, does that answer your question kind of? Or does anyone else in the room have thoughts? I don't know, yeah.
Sometimes that I think that's really wonderful. If I want to be sarcastic, I would tell them how wonderful that would be, because I've been at this for more than 40 years, and I still have things to learn, and I'm learning every day. So if you know it all, like, wow. Like, that's often how, if it was safe, I might respond that way. If I thought they could handle it, because that idea, Susan just expressed it, right there. Still there.
There's another. Did you have more, Rob?
On top of that, thank you so much for bringing that. It's just so interesting. We were just yesterday at a presentation looking at chemistry at UHM. So like a lot of this is coming up, and I think within medicine and within the staff of the hospital, and trying to better understand how we can best address it, and that it exists, and then it needs to be addressed. Yeah. And so I really appreciate kind of your, practical approaches, and I love that like strength-based kind of learning. And then this backlash with mandatory courses, I just wonder how we can address it. One thing Dr. Terry Aldrich talked about is like a racism, there's a racism scale, and that the research shows that depending where you fell on that scale, different approaches work better. For example, strength-based was best for those that were quite racist, whereas like culturally competent courses were better for those that were like more on the allied spectrum. Yeah. So I kind of like that, but I'm just wondering if you even have any more suggestions that like would be helpful to us that are coming from like the medical profession, and how we can apply what you've learned through teaching social work, through teaching in a university setting, how we can apply that to our like medical professionals, our staff in the hospital. Like if you have any advice
I would just say, I always view everybody's learning on a spectrum, right? And that always helps me, I think, to feel maybe, I don't know, more patient and kind where, where everybody is at, even that student you have in the classroom who's very racist or whatever, right? We're all on our learning journey. And I guess my goal always as an instructor is just to help take people a little bit further in their journey and hope the next person can take them a little bit further yet. So I think then maybe that takes the pressure off of there being one course where someone's going to come and get it and walk away a changed person. I think if we have courses where we're able to make those, we're able to teach and to guide and to sometimes cajole even, right, and to have online training and have experiential learning. And I hope in time that those structures will change, right? I don't know if it's not probably like a super dynamic answer, but I think it's an honest answer, right? We all know the institutions we work in aren't going to suddenly become, have arrived by tomorrow. So I think it's those finding those little spaces, right? I guess to be able to bring about change. Yeah.
Susan, thank you. I've got a final question, which I'm also going to use as a bit of a segue to just opening the floor up in our last 10 minutes. You can sit down because I think we can all speak with our, there will be questions, I hope, for both of you. So in the spirit of kind of lifelong learning that we were just talking about, which is in some ways part of our own journey with this work. It's been a theme of some of the answers here, but also this lifelong the lifelong of an institution learning, how we are needing sometimes to return to things we've already tried. We're needing to come around again, this kind of needing to be tenaciously coming back because it's not a quick fix. What I'm interested in, you two are both PhD alumni of the UNBC. There's only a few of you that have gone through. We're a small PhD program, but it's just this sort of broader sense, both in terms of how we're equipping people to deal with the particular issues of things that are only influencing small numbers of in your case, Trina, of women in northern, rural and remote kind of communities, and in your case, really bringing our thinking to this ongoing work of how we're building our capacity to deal with the impacts of colonization that cascade all the way through our institution. So just your thoughts about the sort of moments in your training, the moments in your kind of learning, not necessarily thinking about your PhD program, but your sort of moments where you've seen, it's a little bit of a strength-based kind of thought, because part of what, our theme today, we're carrying on the conversation with Michael Smith. We're also talking with a bunch of trainees later, and we're always at the Health Research Institute wondering how we can be part of fueling these ongoing conversations. So any reflections from either of you about little moments that might not have been at UNBC, you might have seen them elsewhere, where you've sort of seen the kinds of conversations that you think, or the kinds of activities, or the kinds of professional development that you feel like, oh, I wish there was more of that. Have either of you got thoughts in relation to your topic area, or things you'd like to see more of that you can reflect on that help you on your journey as you're moving out of your PhD and into this next wave of things? Hard question, perhaps.
Well, I don't see where I go.
Good.
Down with I think, well, I've joked with you before that I'm Catholic. So like, what happens afterwards, right? And I think, and actually I had a good conversation with Martha recently about that, and she had informed me that there was a post-PhD something. Depression. Yeah. So
post-PhD depression.
Yeah. So, and I what that is, I kind of just trying to be figuring out. So now what? And I think maybe some training around that, maybe some support. Like, what do I do with all this now? And part of it is that I'm in a unique situation where I have a job and I, I'm part of the faculty here. So I don't know, and the part of that's not just my own thing, but what do I do, you know?
Mm. Well, I mean, it's a really good underscoring of a dilemma that we're, and as a health research institute, part of, I think, it's fair to say, we are really interested in trainees in particular phases of graduate sort of training, but we're also interested in how we're supporting our colleagues and peers to kind of keep learning about these big challenging issues. And, you know, in our time-crunched world, sometimes that professional development stuff is the thing that falls off the edge. So even building a culture in our institutions that values it a little bit more. I wonder, it really struck me, there's lots of things in your slide, Susan, that stood out to me, but something about, because the lifelong learning thing is one of my kind of, it's just how I see myself. When you said this is their last kind of moment of learning, which is, of course, you were pointing out this is why we need to pay attention to folks that are at grad school or at, you know, even at their undergrad, at their third and fourth year or heading into that grad school, that it might be their last formal touch point with a formal educational institution. It probably comes back to the questions just here. What else do we do when we're keeping that alive for social workers outside of, in their broader professional development? But you've also heard about for faculty. Have you seen things that is encouraging? Have you seen practices that you think that we could do more of?
So one thing I wish, and maybe part of where that little came from is because I do think a lot of times push for practice, you get your degree, you go into practice, and then there really isn't that, you know, back and forth learning, right? And so I think sometimes it happens where we'll have, you know, workshops or conferences where everybody's invited. Because we kind of are in our silos a little bit, right? Like there'll be a conference at the university, and it's only universities will get invited, or, you know, at you know, Northern Health or with members. So I think I haven't seen a lot of that, but that's something I would love to see. Is let's invite the delegated Aboriginal agencies, let's invite community members, you know, maybe make learning more accessible. Is that part of what you're
Yeah, I mean, I think we're actually learning within, we're a health research institute, and I know that Martha, I don't think this is speaking out of order. I mean, we're also sort of a health capacity strengthening institute, and so that means that we're not just thinking about how we get people to be good researchers, because in both of your presentations you've been pointing out that there's a whole lot of sort of awareness and literacy about the context that you're working in, which is what makes you the difference between just a good researcher to somebody that may be really having impact in the communities you're wanting to serve. So I mean, I guess it's a way for us to sort of, I wonder if there's any comments from the wider floor about things that you've seen or queries about to either Trina or Susan about this sort of question of what do we need to do more of, or suggestions of what we need to do more of as we're building capacity to also to create more of both of you. You know, that we're that thing that allows, obviously we can invite you all into all of our classrooms, but you know, how do we create that impetus where you've been on a big journey with your PhD? But are there other questions for Susan or Trina about that next step zone? Any queries or thoughts? Yes.
Quick question. Do you know where you wanted to be at the beginning of the PhD and you ended up there, or was that a journey in and of itself, figuring out where to be?
I didn't see myself as being necessarily being here. I kind of honestly went to get PhD to share the pleasure of it, which is in hindsight very funny. But yeah, I think when I was kind of going back to I think that is more
And everyone asked me that, like I got that a lot, and I also I didn't know, but it was a personal journey to and then we wanted to sort of kind of create my own program of research.
So I think we are coming to the end here. We've also got, I was going back to a reminder about this, but that's where we're heading now, which is migrating to the NUSC space for some folks who are going to be part of this ongoing conversation. For those of you that are not aware, the Michael Smith Foundation for Health Research is a BC-specific health research funder, and I'd really encourage, even if you haven't planned for it, to come into that conversation if you've got time. And then there's also the work that Shana and Damon and others have just to create a space for trainees. We always know that in people's busy lives, holding the spaces for these conversations is really hard, but it's always worth it. That's one of those tricky things. So I really want to thank both Trina and Susan for sharing with us. We're figuring out with our series things that we want to do more of, and this is really reinforced why getting our PhD alumni back when we can. It's a really big bonus. And congratulations, both of you, on some really inspiring work, and for all of you for being here. It's great. Thank you.
Yes, I'm not going, but